Okay, good morning, everyone. In discussing this session, Rose kind of brought up the fact that a lot of people that are in this room may not be from the health sector, and may not have experience working with the health sector. And so there was a good discussion in the group around maybe we need like a population health 101, like what is population health, or at least what it is from a health authority or the health service perspective. And so Rose said, Leslie, do you want to do that? I'm like, oh yeah, no problem. Yeah, population health in 5 minutes. So I'm going to do my okay, I only have a few slides. So my apologies in advance for all my colleagues that are actually in the health sector because I have completely oversimplified. Okay, so and apologies to everyone in the community development sector because I've completely oversimplified. So, but hopefully it will at least give people a flavor, and it'll also give us, I think, a better understanding of what assumptions we're bringing to this. Because I know that when I first started working for a health authority, which is about 10 years ago now, I came from the community sector. I'd basically never worked for government. I'd always worked with NGOs. And I just assumed that a health authority, professionals, trained, they knew what they were doing, everything from the inside must look great. Yeah. Then I started working for a health authority, and while there's fabulous people that work there, and there is a lot of great stuff going on, I was, whoa, my goodness, okay. And then on top of that, in the health authority, I've always been doing work kind of on the fringes because I'm not a health professional. I actually have a master's in health promotion. So and my background is media communications, social sciences. So I always felt in public health a bit of a square peg in a round hole. So I just wanted to say that as a kind of an introduction so that you realize that within the health authority there's so much diversity that there is no such thing as this monolith that is the health authority. So I'm hopefully can clarify a little bit of that this morning. So what is population health? All right, really, really simply, it is improving the health of the whole population and reducing health inequities between populations. So a population health approach will either be about the whole population. Often universal health care is often categorized like that. Or it might be focusing on very specific populations, however you want to define those populations. And of course, in 5 minutes, we're not going to spend any time talking about that. But key to this is this concept of inequity, right? It's differences in health that are not fair. So I'm sure everyone in the room gets that because we're all working in that idea of community development. So we all understand that basic concept. The second part of this is that population health is about doing those two things, but it's about addressing the determinants of health. In other words, asking the question, why are some people healthy as a group and other people not healthy as a group? It's not looking at the individual, it's looking at it as a group. And as soon as you ask that question, we see that there's specific determinants or factors that determine whether someone is healthy or not. So that's a really important concept in this work too. So often, and again, I've really simplified the language here. The language can be really confusing, and even within health, there's not always a really clear understanding of what the language means. But in general, there are determinants that we would classify as individual risk factors. The idea that the genetics, your sex, the skills that you bring to being able to manage stress or manage your life or your world, those things that are part of you as an individual, those things can be understood as individual risk factors. And those are very different than what we would call social risk conditions. And the social risk conditions are those determinants or those factors that a society makes available to its members. That's a really easy way to distinguish between the two. Individual risk factors are those things that are inherent in the individual, which tends to be the focus in our society. People say health, they think about, what's my blood pressure and am I overweight and what's my genetic risk for whatever. But in population health, we are really focusing somewhat on those individual risk factors. So we're trying to change some of those risk behaviors like physical activity and healthy eating. But really, we want to look at the determinants of health or the social risk conditions. And the key there is these are resources a society makes available to its members. And that includes what? Education. Housing. Income. Early childhood development. Access to health services is also one of those. So you can see it's very hard to put these things in boxes, but you guys get that. So we're going to start from that assumption. All right, now what I want to do is just briefly illustrate then what are the implications in the structure that is a health authority or a health service system. The first thing to understand is in the health system, we're held accountable for achieving certain improvements in health. And the way we define these is actually quite makes your head spin. We talk about things like potential years life lost. We talk about mortality rates. So the age at which you die. We talk about things related to disease like incidence and prevalence. Incidence being the number of cases per year and prevalence being the number of cases in the whole population. We talk about disability-adjusted life years. So we want to know, it's also about quality of life. It's not just about whether you have the disease or not. It's about what that quality of life is like for those people, and we try to evaluate that. So we have these things called dailies. There's just buckets and buckets of these things. You'll also see in the work that we do that there's risk factors, which I'm sure you're all familiar with. Things like smoking and obesity. We look at rate of low birth weight. We look at rate of teen pregnancy. All of these things are risk factors for poor health. And again, huge long lists of them. And risk conditions like income, high school completion rate, those kinds of things. So these are all the indicators that in health we're held accountable for, especially the morbidity and mortality ones, of course. But what's not captured in these indicators? What about things like indicators from the happiness index, right? Those things are really critical and important in people's well-being and health. But in the health sector, that's not what we are required to link our programs back to. So you can see an obvious challenge for us in the work that we do around community development, because those kinds of indicators maybe, in fact, are more important than these particular indicators, right? So this is one of the challenges. So what I want to do is I just want to illustrate a few what I call tensions within the health sector in doing health improvement or community development type of work within the health sector. So on the left are more of the individual risk factor types of issues, and on the right are more of the social determinant end of the spectrum. So you can see that in the health sector, this concept of improving health, very well accepted, very much a part of an objective of our programs. But this idea of decreasing inequity is a little bit more difficult. It's out at the other end, and it's something that the health sector wrestles with, is what does it mean? What is inequity? Individual risk factors, of course, social risk conditions. Client-patient services, which is what a health sector, health services are all about. Quite often it's that one-on-one patient care as compared to community development, which is the reason that we're all here. So those concepts create tensions within the health authority. People that work in public health tend to be working more off on this end, and people working in the care end tend to be working off on the other end. So today what you're going to be seeing is a lot of examples from this community development end, but what I'm trying to do is put it in the context for you of the whole health authority, because health authorities have billions and billions of dollars in their budgets. But public health, which primarily is the area that focuses on the community development, is 3% of the health budget. 3%. So health services are roughly organized around these concepts. My apologies again, I have really oversimplified, but all of the health authorities are set up a little bit differently. We have hospital and emergency services, home and community care services, residential care, which is primarily the seniors, right? Mental health and addiction services, public health, and then we've got this group here of what's often called primary health care, although inside the health sector, you can't get everyone to agree even what primary health care is. So we have things like chronic disease management, which tends to be outpatients, people with diabetes that come in to see someone to help them manage their diabetes and stay healthy. Screening programs like cervical screening, mammography, that kind of a thing. And then we have these family physicians, which actually aren't inside the health authority, right? They're in the community, they're entrepreneurs basically, they're private businesses, and yet they provide a service that's paid for through MSP. So this is the structure of the health services. So if you look at that, where does the focus on community development or social determinants of health primarily sit? Public health, right? Primarily. Not that it doesn't sit other places too, but, and I'm going to illustrate what that looks like in the different sectors. Oh, actually, one other tension. So there's one other tension that I just want to talk about, and that is, for example, if you work in home and community care, you're often, if you're paying attention to population health principles, and that's a big if, okay? It's not always common practice. If you are, you're probably paying attention to, I have these people with these risk factors. I have these people with poor health. I have these people with low education, with living in poverty. What I'm trying to do is I'm trying to mitigate. I'm trying to make sure they get the services. I'm often focusing on accessible health services, whatever that looks like. That is important, very critical work, and it is population health. But they often, in that world, are not paying attention over here, which is the changing the underlying factors, which is what we do as community developers, people working in community development, working here. Not that this isn't important. But you can see that in a health sector where you're seeing individual patients and clients, yeah, I'm just about done, Rose, where you're seeing individual patients and clients, and where you're judged against those indicators that I showed you earlier, you can see why this is where the resources go. But today, you're very lucky because you're going to be hearing some stories from this end. A couple examples. In the emergency department, if you're focused on accessible services, you might do something like have an addictions counselor in your department so that you can follow up with chronic mental health users. Because any emergency department can tell you exactly who uses the emergency department as their private physician. But if you wanted to focus on changing the underlying risk factors, your emergency department would have a strategy to join a mayor's council around developing accessible housing. But how many emergency departments do that? And can they do that? In diabetes education, for example, you might train staff at the Friendship Center to provide basic diabetic education, and that would be an accessibility issue, mitigating the risk factor type of a strategy. But if you really wanted to get at the root cause, maybe you'd be doing, food security, community gardens, good food box type strategies. How many diabetes programs, and I mean the ones that provide the services, actually do that kind of work? Not many. And my last example is public health. Public health is really known for the well baby clinics, right? The immunization, the health education. But if public health really wanted to work upstream, do more community development, they would be focusing on things like participating in an annual child poverty report card to try to advocate for change at that level. So like I said, today what you're going to be hearing about are examples on that community development end, because even though we don't have a lot of resources and even though the system is stacked against doing that kind of work, we still manage to squeak it out. We still manage to do it somehow. And so you're going to hear some of those examples. And this quote is just from one of the first public health doctors. And he right away recognized that change is ultimately political. And his idea was that public health is therefore political. So you're going to hear some of the political stories. Sorry, Rose, that's the best I could do.
Thank you, Leslie.
Okay, you're welcome.
I'm Jamie Brown, and I'm the leader for Healthy Living, Healthy Communities in Fraser Health. So I'm here to talk about what we're calling Collective Action for Better Health, which is our Healthier Community Partnerships initiative. Oh, boy. Oh, thank you. So I'm going to use the analogy, it's like building a house. And so I actually took this from a presentation I did with the executive directors in our health authority. I'm going to use the analogy, it's like building a house. And so I actually took this from a presentation I did with the executive directors in our health authority, because keeping in mind, just going along the lines of what Leslie just talked about, when I'm talking to senior leadership at Fraser Health, they're not necessarily thinking the same way that we're thinking in any way, shape, or form. So I really have to kind of compartmentalize to explain how we can move forward to do the work that we're doing. So this is what I used, is building house, because everybody can understand that. So in Fraser, I'm very, very fortunate to have a senior leadership, in fact, our CEO, who came from New Zealand, and I don't know if anybody in the room really knows much about the New Zealand health services, but they have a very progressive health services system where public health and primary health care work together, and they do a lot of work around community development. So my CEO is very, very adamant about having really strong relationships with the community structure, in particular municipalities. And so this is kind of where the Fraser system came from. And so right now we're kind of laying the foundation of that. We're going through the transition planning from what we've done previously to where we're going now. And so part of that is actually having senior leadership commitment. In our organization, it is part of the performance plans of the senior leadership team to be involved in population health. So not only on the healthcare sector, so when Leslie was talking about emergency rooms having, working in population health, in our health authority, they're actually mandated to have a population health initiative within their emergency room service plan, so, or emergency system service plan. So it kind of gives us a bit of an advantage in the sense that I don't have to beg to get any of them to listen. They actually have to build it into their service plans. So we have a good working relationship with them. We also have all of our executive directors are responsible for communities. So not only do they have health services, they also have a community and a community hospital that they're responsible for. When they have the community, they are responsible for being kind of the face of that community and working with the municipalities. So each of our executive directors are mandated to do that. So there's that level as well. Makes it a lot easier to get into senior leadership meetings to have a conversation. So part of that for us is municipal engagement. We have a mayor's committee that sits, all of our 20 mayors across the health authority sit quarterly with our CEO and senior leadership and our board to discuss issues of concern both on the healthcare side and on the population health side. So that's kind of where this all started for us. So our mayors actually signed a letter of agreement wanting to have municipal engagement with the health authority in a more formal partnership way. It's also part of our strategic imperatives, which is our strategic plan under the term progressive partnerships. There's a whole section on progressive partnerships, one of the 4 strategic imperatives. And so in that, all the progressive partnerships are about the Healthier Community Partnerships Initiative. So we actually have indicators of what we need to do within this given year and within the next year, and talk about it at our quarterly business meetings. We also are in the process of working towards having a better defined relationship between the different portfolios and having them all work together. I have a team of 8 people that report to me. In fact, half of them are in this room because they're wondering what I'm going to say about them right now. So that are assigned to work with the executive directors and the communities in terms of formalizing these partnerships. So we're kind of in that stage, so just so you know, this is the future state, most of this for us. And this is the putting up the walls stage where we're talking about the knowledge transfer, which is really about the asset mapping for us. We need to do internal asset mapping because, as you can well imagine, we have 23,000 employees. We're the largest health authority in the province. We really don't know who's sitting on what, who's doing what in our communities from our own health authority. So we really need to get that figured out so that we can best work together. The idea of the whole partnerships piece is not to replace what's already happening in the community. It's just to augment it and help bring people together kind of for that collective action. And then we're looking at the workforce development piece, which is around the training and education, because as Leslie already alluded to, we have quite a ways to go in terms of people's understanding and knowledge within our own 4 walls of population health as well as outside. So that's a big, significant piece of what's going to happen over the next while. We'll also be having these local collaborative tables, which is about creating internal readiness so that when mental health workers are sitting on different committees within the community, they know what they're talking about. They know how to connect it to some of the things that are happening in the partnership. So that's our goal, is to have everybody involved, because 8 people can't replace the 50-some, 100-some people that are running around each of our communities. So the idea is to start making those linkages so we can work more effectively. And then we're going to be adding the fixtures, which is around our overall strategy. So one of the first places we're starting is with these snapshots for better health, which is really kind of the expertise around the data piece. The health authority, as Leslie said, collects a lot of data around health status of the community. Our medical health officers are mandated to report on that health status to community. So we're actually taking a lot of that information, kind of shifting it around a little bit and adding some population health strategies to it. So it's about 3 or 4 different indicators and then 3 or 4 different strategies that we think that particular community could do to help support some changing of the community health status. We're also developing a comprehensive communication strategy across the organization, hoping to kind of highlight the different things that are happening within each of the communities. And then, of course, the big one is the engaging citizens as partners, because one of the things that our health authority really believes in is the idea of people getting feeling a shared responsibility for the health of their community and the health of them as individuals. So it's not just about the health authority providing services, it's about citizens recognizing that they have a part to play in terms of improving the health of their community and themselves. And then this is the final touches. Now we're a ways away from all this. We do have some more formalized partnerships. We're in the initial stages in a few communities, but this is really where we're hoping to go, which is having these formal partnership agreements at the municipal level. Now that will take different shape depending on the community. Some communities have well-established committees that we're just working with to start to look at this picture. Other communities are really starting at square one and don't have anything of this nature. The other thing is doing the issues prioritization. I mean, in an ideal world, you'd be able to work on a million different things, but you really can't do that. So we're looking at identifying a couple of things that we can work collectively on. And then, of course, the community action plans. So our hope is to get to a stage where there's actually community-wide action plans on better health. And that's pretty much it for where Fraser's at.
Thank you, Katie. Okay, yeah, we move into the interior of the province. Good morning, everybody. It's really great to have this taste of all the work of the health authorities and how it looks a little different everywhere. But I'm going to talk about interior health. And just for some contextual pieces, the department that I'm coming from, again, population health, and our mission is to have a look at improving health and promoting equity to residents through partnerships and evidence-based actions. Our population health team, and there's a visual on the next slide, but consists of those kind of five key priority focus areas. So community nutrition and food security, injury prevention, tobacco reduction, surveillance, and then action on the social determinants of health. That's where I fit in, and I'll talk more about that in a moment. Just the visual. And a reminder that here we are, this little team of about 20 FTEs, and like Leslie and others have mentioned before, public health is just 3% of the budget, and then on top of that, population health has a little sliver, somewhat similar to what public health sliver is of the whole budget. So we, as that relates to how a health authority is involved in community development, it's, we're the ones that you can put your finger on. They're doing community development, and yet it is the health authority that has little roles in it all along the way. So our department is a department that ensures a broad approach to health, to have a look at those social, those political, and economic factors. It's the department that ensures that healthcare and population health are not competing, that they're complementary approaches, and ensures that the public and community are involved and participate in health and planning. We focus on the creation of healthier environments and healthy public policy, and we also ensure that there's staff and actual resources that are dedicated to the determinants of health and health equity issues. So I thought what I'd do for most of my time is talk a little bit about some examples from each of those bullets and how we carry out that work, what that looks like. I am going to, here's me. I'm one of these two FTEs. And most of my examples will come from just that piece, but there are a few that are smattered throughout that whole population health department. So I hope it gives a taste of where we're at. Our broad approach to health, looking at those social, economic, and environmental factors that influence health. There's a few examples here. So my colleague that's also a population health facilitator, her portfolio area is focused on mental health and addictions. Not on that service provision side, as you might conclude, but it's more about those mentally healthy communities and how do we get there. So Betty is really involved in Friends for Life. It's a it's a health promotion, a mental health promotion program based in schools, really about looking at lowering depression and anxiety in those school-based years. Some sustainability work is also woven into what we're doing as well. So bringing those partners together, making sure that there's a health lens in that sustainability work in communities. An example here is this poster was just from an event a couple of weeks ago, where the dialogue started with kind of a social planning table in Kelowna. It's actually a poverty action group. And they wanted to engage with business and having a dialogue kind of about those living wage, cost of living kinds of concepts in their community. And that's where we started, was kind of engaging with business. And it was quite successful. By the end of the event, there was interest from the chambers. There was interest from 27 business owners or representatives that were interested in being engaged in some kind of conversation about living wage work, about cost of living in the Kelowna and the Okanagan Valley communities. Here's a piece about the complementary and not competing paradigms, that we want to ensure that population health is seen as an ally and not competing with funding and dollars from the big pie that's available. And so one way that we did this, and the position that I'm a part of and my colleague Betty is a part of, are called Population Health Facilitators. We've just wrapped up our first fiscal year, I guess is the way to look at it. So we're still in that developmental process that Jamie was alluding to as well. So in the earliest stages of that, we had an advisory committee, and it consisted of people across the health authority. Some whose staff were already involved in some community development kinds of activity. Some that they themselves really engaged in their communities wherever they worked. So it was a really diverse team, and lots of knowledge there about working internally to get the population health and the social determinants of health on the radar of other teams and other departments. It also involves an ongoing inventory, and Jamie talked about doing this kind of mapping internally as well, but that it's an ongoing process of acknowledging that there's community development work that's already happening in the health authority. There's public health nurses, there's integrated health networks, and mental health and addictions often. As it's been acknowledged, there's a bit of a tension. We don't always work from the same definitions, but it really is a importance to acknowledging that community development is not owned only by population health, but it's something that happens throughout the health authority. Public participation in health and planning. So here's just another example of some of the work that's happened. And Patty from the Canadian Cancer Society was one of the partners in Traction for Community Action. It was a series of workshops really looking at social planning and that tool and how it relates to the social determinants of health and kind of leveling out those inequities in communities. So our roles as population health facilitators can be a piece of this, providing some support to social planning bodies, some capacity and skill building like the workshop, and in some cases facilitating some planning processes. Okay. Again, it's also back to using those folks in the health authority who are already engaged in their community, because Betty and I cover all of interior health. So that region, the size of Britain, and I'm sure Teresa can appreciate this too, the size of Britain, the BC border up to Williams Lake, the Alberta border over to, Merritt, it's quite a chunk of land. So to be in all of those communities, providing some support to each of those communities would be quite impossible. Instead, really working through those people who are public health nurses and addictions counselors and those kinds of positions throughout the health authority in communities. Ensuring a focus on healthier environments and healthy public policy is another piece. So one example of work that I've been involved with, this is a list of some examples that our whole population health team has been involved with. But the first one there, access to physical activity policy. An example was in Cranbrook, and Cranbrook is actually the community I live. I had attended what our mayor calls a brown bag lunch. And our mayor, once a month, opens chambers and kind of invites the public in to say, what are your concerns? And so myself, along with housing and social development representative, we went and just kind of said, any ideas about an access pass? And the mayor said, communities actually have that? And we said, oh yes, and let us tell you about that. And so started a bit of a process of taking a look at some options and working with both the local recreation department and an advisory committee to try and get an access pass for physical activity at our leisure services and recreation facilities. So it's just one small example. And then the fifth bullet at that slide way back at the beginning was really about resources that are dedicated to health inequities and social determinants of health work. And like I've been mentioning, Betty and I are two positions, but I think also as these positions have unfolded, it's really brought about a recognition in the whole Department of Population Health that, yeah, we're doing this work, and we're doing it at the community level with a community development approach with a focus on social determinants of health. So a bit of our approach overall is just to foster some public dialogue, to increase access to local information, identify and engage stakeholders from multiple systems. So, a few that have come up have been Ministry of Child and Family Development. I've talked about that. Ministry of Housing and Social Development, local municipalities, those kinds of partners. And then acting as catalysts to support and build existing community organizations. Some of that's about social planning councils and those kinds of involvement. Coalitions, it could mean housing coalitions, it could mean poverty coalitions, that kind of work. But what's defined some of our success has been these five kinds of approaches or five key pieces. That is that our actions are strategic. So finding some common ground about what the organization, the larger organization, is already involved with, and inserting a bit of a population health approach. Some of Leslie's examples talked about some of the ways that we do that. Diabetes, for example, working with mental health and addictions, those kinds of things. But always framing community development work as it relates to Model Core programs also is a bit of a strategic move. Liaisoning, so this is about establishing some of a business case and learning the business of the health authority and using their language and melding it with organizational and community development approaches. Using evidence, those short-term results in a long-term context. Brokering partnerships, again, there it is. And leveraging is important to just ensure both that there's support internally, but also some recognition of the need and the importance of doing population health work. There's a whole slide missing, but hey, whatever, that's how it goes sometimes. And the last slide was a beautiful bridge. And the beautiful bridge was really just a way to talk about, that is funny, to talk about some of the challenges. And I think Leslie covered some of this very well, too, so that the the fact that the slide's missing isn't a huge deal, but there is a tension that exists in health authority folks doing community development, and especially when we're talking about those key principles of community development, right? If we're talking about grassroots work, working with people directly, face to face, giving them that space to create their own vision, their own goals, their own directions, and then working in a consultant kind of role, there is a bit of a tension there when the report back is so important. The report back to the health authority, right? Another tension is just that dealing with communities at a real face-to-face level in community development, to be, personally in the here and now, and covering a huge region, and keeping the use of resources in mind isn't always possible. And so, there are those tensions. But we're working really hard in population health to ensure that the whole health authority isn't in the internal damnation line. So there we go. Doing what we can and bringing out those really good examples, not just in population health, but throughout the health authority, public health, mental health and addictions, all those other areas. So thank you.
Good morning, everyone. I am presenting on behalf of Population Health for Northern Health. I put both my positions up there because I do actually think having a connection to the university has been really good for us to get students out of classrooms and into practical learning opportunities, and we get cheap labour, often free. Like my colleagues before me, I want to talk about how population health fits within Northern Health and how we make that work in practice. Our region is the size of France, and I'm it for healthy community development. We have a population health lead, and we have HEAL, which is a program, and just recently we did expand. And what we're doing is we actually consider Northern Health a community too. So we're acting both inside and outside of Northern Health. So when we talk about community development and working with community, we're taking those same principles internally. Because we're small, we consider ourselves a bit like a virus, quite small but ultimately powerful, can fell the strongest of individuals. Probably not healthy. The Population Health Council existed in Northern Health, and about 2.5 years ago they decided they would hire a lead. So we have a population health lead. About 2 years ago, a position called Community Food Security was reworked to be Healthy Community Development, and I applied for that position. It looked like it had been written for me. It's exactly the things that I cared about when I was teaching at UMBC. So you can see my blue position, showing that I'm inside Northern Health, but a lot of my work is actually outside in community. I'm working very closely, hand in hand, with Julie Kerr, who's just a genius brainwave kind of woman who can actually manipulate the system, which is what you need. You need to be able to speak that language. So what's happened is she reports directly to the medical health officer, who reports directly to the executive. On the Population Health Council is all of the senior managers from across the region. They all sit on that council, and it's two big indicators of success. Northern Health just redid its strategic vision and planning, and population health is one of the 4 pillars. The other big success is every manager has to have at least one population health goal in their performance management review process. Another indicator of success in a time of cutbacks, we're actually growing. We've just acquired injury prevention and the community nutritionists. So we're actually, we're beginning to pull together elements. But the most important thing for us is it's not about we know population health. It's how do we talk to the environmental health officer who wants to go into a community and shut down the community potluck. is to actually get them thinking about what have you actually done to improve health in that community? Have you not, in fact, just further endangered that community? So how do we work with people who know? And this is the big challenge. People who've acquired degrees and they're professionals and they've got code of ethics and standards of practice. And we're coming along and saying, wait a minute, we'd like you to do your work differently. Because that notion, if we build acute care beds, we're going to fill them. And we really need to start working upstream. So working with our community, within Northern Health, we've used this story, which I'm sure you community developers know, of the village upstream that just becomes so good at pulling drowning people out of the river. They boast about how fast they can get them out, but never think about what put them in the river in the first place. So our work sometimes doesn't look like health. When I'm sitting out in a community and having a hell of a good time, I sometimes worry if I'm seen doing this, will I lose my job? Because it sure doesn't look like health. So the other big tool we've used is the iceberg. And you've probably seen this. The tip of the iceberg is the things we can see and measure. But we have to start working below the surface. And in our iceberg, you can see that the further down you go, the more complex and subterranean the issues are that impact people's lives. So moving from that place of Rose is a heavy smoker and I'm going to lecture her about all of the things that are wrong with her lungs, and Rose says back to me, as I have heard a community person say, if I quit smoking, I'm going to kill my husband. It's the only thing between me and jail. So is getting Rose to quit smoking actually where we should be working? So when you look at our...
I love her. She's my friend.
So when we look at our health work, we very much, as you can see, we don't have positions or titles, partly because we don't have the people and resources, but also because we want the communities to say to us what are their issues. And if it's domestic violence, let's work on domestic violence, and the quitting smoking will come down the road. Does that make sense? So it's a real challenge then to talk to professionals who care. They've invested so much, and now we're saying we want you to change how you work. So we've used the acronym IMAGINE. This was invented by a couple of Northern Health folks, David Bowering, the medical health officer, Lorna Med, who was a medical health officer at the time, Joanne Bays, who was the community food security lead, and myself. And we came up with these are the 7 principles. The word imagine actually presents the 7 principles that we use to guide our work and that we use to encourage the professionals within Northern Health to think differently about what they do. So the first one is investing upstream. We've got to get to people while they're healthy. The list of indicators that was presented at the first, and they're called health indicators, they are no such thing. They are sick indicators. So we want to move upstream to actually figure out what would be health indicators. Multiple strategies, that you can't rely on just one way to do something. You've got to think of many different ways to do it. Addressing the determinants. We've even quit calling them the social determinants because people in the harder sciences don't pay attention to us. So we just talk about the determinants now. Grassroots engagement, that the people who live with the issues are the real experts. We need to go in listening, and that's one of my great purposes is that those of us, whether we're community developers in organizations or in grassroots community places, or we're inside of Northern Health, we've got to learn to shut up more. Intersectoral collaboration, that we've got to learn how to collaborate. We've got to learn what that really means. Nurturing healthy policy, the idea that we don't have legacy, no matter how good your work, and HEAL, the Healthy Eating Active Living, is a brilliant example of that. Funded as a diabetes prevention project, became an amazing community grassroots movement. For 3 years, got extended funding twice for 2 years, then became a community-based movement and nearly folded. It's now within Northern Health. Northern Health is really, it's the cuckoo in the nest. This is a community-based organization driven by community that Northern Health is funding and supporting. And then finally, evidence-based. We're actually moving, I think, towards now evidence-informed. There's a lot of problems with just evidence-based, so we're talking about evidence-informed, meaning we can bring our bodies and our experiences and our knowledge to the table too. So in that slide, when you get it, you'll see that there's a challenge and a reassurance for each of those. So this is how we think about this within Northern Health then, is that we think of our goals as not the end but the beginning. And this is really difficult for us to think of because we put the goals and we're going to get there. For us, the goal is where we start. That's what we want to be working from, not working towards. And an example is we have worked with environmental health officers, very good group of people, good spirit, great intelligence. And the workshop we did was asking them to wear their enforcement hat and then their community development halo. So even how they write a letter to a daycare shifts. And you become somebody that the community turns to ahead of time to figure out how to do it right. And it doesn't mean we're asking you to abandon your standards. Absolutely, you're still going to have to be, excuse my language, the hard ass sometimes, but that's not where you start. Your goal is where you begin. If you want a healthy community accessing safe food, start there. Don't think that's where you end. Pragmatically speaking, because we're so small and we have limited resources, we really do convert and recruit. And some of our best purveyors, if you don't mind that word, of population health is health authority folks that have actually got this message because it begins to make sense. We're asking people to use a megaphone and talk to a lot of people, not the one-on-one whisper. And actually, the professionals become our biggest allies in this work. And I would say that notion of tension, if you remember, if we keep the balance right, we would have a tightrope that everybody could not just walk on, they could go out and dance. So I was asked to bring a story, and I have so many. That I thought I would just give you like Aesop's fables, just little snippets of stories with the moral from each one. And the first one is get the hell out of your office. The more opportunities you can have to actually put your bum in a seat in a community, the better off you are. That piece about relationships takes you moving, literally, figuratively moving. And I know that's tough because the reality is that emails multiply like rabbits when you're away from your desk. The other thing is we don't come into a community and say, my God, your rates of TB suck. We got to do something about this. We actually go in and listen. And so one of the presentation I've done 3 times now for 3 different Aboriginal communities actually used historical photographs of those communities and then talked about this is how the people on this land used to live and this is how they were healthy. So communities see themselves as resilient and strong and with a proud heritage that they can begin to reclaim. So those presentations, like I say, it doesn't look like a health presentation, but it's really been well received. And in fact, in this photograph, the elder came up to me at the end of the presentation and said he could see his grandmother, his mother and father in that picture. And that's a very different picture of how Aboriginal communities are often presented. There's deficit and problems. You have to trust your skills, the capacity to take risks and be innovative. So, for example, the World Cafe, which some of you may know as a methodology, adapt it. It's well tested. It isn't going to fall to pieces because you know your community and know that if you just tweaked it this way, it would work really well. So in this case, the World Cafe we adopted to the medicine wheel and did a consultation with the downtown street people in Prince George for smart growth on the ground, a 4-day charrette that they had planned. It was so successful that they were some of the people came and presented at lunchtime to that group. Out in Telegraph Creek, the survey, we put it up as a graffiti wall. There were still people who filled out a regular survey form, but elders were telling kids what they wanted, and the kids were running up and writing it on the wall. You know, we may not have got the input from the elders if we hadn't thought about how else can we do this. So trusting the skills that you bring. The other thing is, and this is something I fought for a lot doing research from UMBC, is the right to give honoraria and the right to have food. That if people are hungry, they cannot contribute. And food is central to so many different cultures, from Aboriginal to Armenian. Gathering around food matters. And so being able to actually take the time to eat together. I mean, Jesus wasn't stupid when he did the Last Supper. You know, there's something about eating together. Time?
Wrap up.
Okay. So really the understanding that everybody who comes to the table has something to bring. They have strengths, they have ideas, they have things to contribute. I'll just finish with the Stone Soup Coalition, which emerged from 4 women talking about how food banks, it's not working. Feeding hungry people and giving them a full tummy isn't the issue anymore. This coalition came together, anybody who's providing emergency food resources. We then got some funding from Ottawa to do a community kitchen with people who are homeless and who had now had a home for the first time in their lives with a fully equipped kitchen and didn't know how to cut a green pepper, had never seen a whole green pepper. And this group of people, I have to tell you, at the beginning I was terrified. They're coming from places with no trust, a lot of baggage. You can't ask anyone for help. And I'm thinking, we've got these guys in a room with knives. I thought, what have we done? 4 weeks in, it transformed from tell me what to do to craft dinner to make it taste different to doing every week was a different country. The coalition around this has grown. We now have a city councillor on it. We have different social service agencies. And we're now talking about the Stone Soup Coalition actually becoming a food policy council. So again, this wasn't us going into the community and saying Prince George needs a food policy council. This is the group coming together and saying, you know, there's lots of community gardens going. How do we bring together the successful ones with the newbies? So there's a lot of the work. If you trust and let it come to you, which is hard to do. I sometimes worry that I'm going to get fired. So Imagine is the major tool we use. I then took Imagine and showed you how it worked in each of those stories. Each story illustrated a different element, and that's how we manage with only 3 staff to make population health, which to me is code for community development work.
Thank you, Keith.
So I'm Peter Brookman. I'm with Vancouver Coastal Health and part of the SMART Fund team. And the SMART Fund is it's part of the population health team, which is under public health. And we've been in operation for, I guess, about 10 years prior to Vancouver Coastal Health, and then moved into to VCH when everything was kind of amalgamated. And we're a little bit unique in terms of being a funder, and I sort of say that right off the bat because usually folks come up to me afterwards and say, "This sounds great! I've got this amazing project to fund." And so this is by way of explaining what I might explain later. We have for a long time been funding long-term programs. Which is a great place to be. We really believe that funding a program over a long period of time is going to see really much deeper results than doing something over 1 year or 3 years. And the focus of our funding has been looking at vulnerable populations and looking at the upstream kind of work that we were talking about. So the social determinants of health, things like social isolation, food security, access to health services, things like that. And looking at the communities that are in VCH and really looking at the assets that are already there and saying, all right, folks in those communities know what the health issues are good at identifying them, have a lot of strengths. What can we add that's going to build that capacity from within to really be able to foster that kind of change, both for individuals, and this is sort of where those tensions are, both for individuals and ultimately as it ripples out into those communities and strengthening those communities to be able to really address those types of health issues. And as I was thinking about this presentation, what I realized really is that our work is the work of the funded programs. They do amazing stuff, and they work with a huge range of different population groups. It's seniors, it's mental health consumers, youth at risk. There's a huge range. There's also a huge geographical range. So Vancouver and Richmond was our kind of original base, but we now fund programs right up to Bella Bella. And there's about 80 of them that are receiving funding right now. So it's about just under $4 million that we have go out into the community. The great thing about long-term funding is that we can really start to see some real change that's happening, and there's some real stability for communities. The downside is that when really exciting new stuff comes up, it's that much more difficult to be able to try to direct funds at it because it's essentially all kind of accounted for already. So we're kind of in that interesting position. What I want to do, we've done a couple of videos that really look at some of our programs and the work that they do. And this one is about Immigrant Services Society and a program that they run based on peers. And it's incredibly powerful. It really, I think, illustrates both that individual capacity building that happens and then how that kind of ripples out into the community and builds the capacity of a lot of different communities in the Lower Mainland, certainly. So I'm going to let it speak for itself and play it.
I left everything behind. I was building my career and it was, just gone like that. But Canada really welcomed us in the best possible way, and there are many programs that help, and the CrossCultural Peer Support Group program did not only help me with my experience, it helped my family as well.
It was not fair when I came because I lost my husband, I lost my job, I lost my house, my private clinic and everything. But now I always think about my children, and I always thank God that it's the reason that I'm alive and I enjoy my life with them.
The concept of the cross-cultural peer support program, it's the power of bringing together, in this case, immigrant and refugee women who share similar experiences and who, up to them coming to the program, have felt feelings of social isolation, of being alone in dealing with the challenges that they faced, in some cases as lone parents, after spending years in refugee camp situations.
The first part of the training is we're training the women to learn some skills on how to facilitate a group. And group facilitation would include things like empathic listening, how to communicate in a respectful way, given that people come from different cultures, and how to listen to the stories that women share without making any judgments, so then they feel safe.
When I came to Canada, I lost my way. What can I do? Because nobody accepted my certificate from my country, although I was a gynecologist and I had 22 years education. That's because I lost my way. What should I do? Where should I go?
The second part of that is to actually go into their communities and co-facilitate a support group in first language, because that's where the need is. As they go through co-facilitating the sessions every Saturday, they feel that they are giving back to their community, and they feel good doing that because as women themselves going through similar experience, they're in a position to share information and to feel like they're in solidarity. They are one with their community in being able to embrace the challenges collectively as a group.
Many of them have experienced lots of difficulties, some of them violence they have experienced or they have witnessed. And coming here, not only that they have to deal with this, they also have to deal with another stress of integration, because language is the first barrier in many immigrants' lives, and as well adjusting into the new culture. There's cultural shock, there's isolation and frustration.
The ability to come together, 16 to 18 women coming together over 12 Saturdays, just over 80 hours of training, and giving them the opportunity to share their own experiences of coming to Canada has been profound. And it's about increasing the individual capacity of these women so that they can give back to their communities and to support their peers who are facing and have faced similar experiences.
The other piece is to promote awareness and share information that affects their lives, such as welfare rights. And cross-culture parenting is another thing that affects many new families because they're in a new country and they don't quite understand how things are done here.
My daughter, when we came to Canada, she was a teenager, and the way that she dressed up and she put makeup on, I was not happy with that. I wanted her to follow my culture, and she always argued with me, Ma, if you loved your culture, why you left your country? We supposed to dress up like that. Then when I came to this class and I learned how to talk with my teenager daughter and how to get along with them, I'm so happy because now there's no argument, and she's very happy. Now we are like two best friends.
And they also learn things around health, physical health, mental health. So if they're depressed, where do they go? What do they do? And the women in the program, in the training, learn about this. And when they go to their support group, they share this information with the women.
The program makes it easier for you to experience the things that all newcomers experience in Canada. And by sharing it with others and hearing from others, that makes you more empowered and not feeling lonely, knowing that there are peers.
We can see how this program has removed the feeling of isolation, how women have felt more sense of belonging to the communities in which they live in. It provided them with increased confidence and self-esteem to tackle the myriad of challenges that they face, as part of their settlement process.
When I think about Canada, the first picture comes to my mind is multiculturalism. And in one room, having women from all over the world, that is amazing. Hearing about their cultures, hearing about the stories they have to share with us, that is beautiful. There are things that we never thought about, but once you hear it, it never goes out of your mind. And you just have to be there first half an hour and see how fast they start interacting. And always, my first speech is how different it is at that moment and how it will be when the day comes and they graduate, how fast the time will fly over these sessions. There is not enough. I mean, the words can't describe what a difference the program makes in our lives. I'm talking as a former graduate myself. The difference is where I am today. That is the result, and it was my stepping stone. And I can say that I can easily apply anything I want today because I have the power and I have the self-confidence.
So every time I look at that, the last little thing is VCH, and it's promoting wellness, ensuring care. And this is all about the promoting wellness part of that. There's a lot of ensuring care. This is the promoting wellness. Anyway, I think I've probably eaten my time, so I'll let questions come afterwards.